Good morning, everyone. Topic for my today's seminar is automation in hematology laboratories. Going back to history, Antony van Leeuwenhoek invented and first used microscope. Man who changed the world of counting was Wallace H. Coulter, an electrical engineer who developed and first applied Coulter principle. Automation in hematology includes cell counts, with automated hematology analyzers, diagnosis of hemoglobinopathies by high performance liquid chromatography, flow cytometry, automated coagulometers, and automated ESR analyzers. Automated hematology analyzers. The complete blood counts, including DLC, are the backbone of any laboratory evaluation. Modern hematology analyzers provide additional parameters when compared to manual procedures, helping in better diagnosis. Types of automated hematology analyzers. There are two types of automated hematology analyzers: semi automated analyzers and fully automated analyzers. In semi automated analyzers, they require some steps to be carried out manually, like making a dilution of the blood sample, and are capable of evaluating a small number of variables. Whereas fully automated analyzers measures multiple parameters and require only anticoagulated blood sample. Components of cell counters. Hydraulics. It includes aspirating unit, dispensers, diluters, mixing chambers, aperture baths, and hemoglobinometer. Pneumatics. It includes vacuums and pressures for operating valves. Electrical systems. It includes analyzers and computing circuitry. Principles of working. Various principles are involved, which include electronic impedance, radio frequency, optical scatter, which include laser light scatter, flow cytometry, and chemical dye method. Electrical impedance. The principle of electronic impedance was first introduced by Wallace Coulter in 1950. This depends on the fact that blood cells are poor conductors of electricity. Two chambers filled with buffered electrolyte solution are separated by a small aperture and constant DC is applied. When a cell passes through the aperture, it displaces a volume of diluent and increases the resistance, thus producing a voltage pulse which is then displayed on the oscilloscope. Computing and generation of graph. Each pulse is recorded as an oscillation, the height of which is proportional to the volume and size of the cell. These oscillations are rearranged according to volume interval to form a histogram. Variables measured by using electronic impedance. In RBC count, MCV, size distribution histogram, RDW, and other measures like hematocrit, MCH, and MCHC are derived. In WBC, total count and three-part differential including lymphocyte, mononuclear cells, and granulocytes. In platelets, platelet count and platelet histograms, which gives mean platelet volume and platelet distribution width. Optical light scatter. A diluted cell suspension flows through an aperture so that the cells pass in a single file in front of a light source. Light is scattered by the cells passing through the light beam. The scattered light is detected by a photomultiplier or photodiode, which converts it into electrical impulses that are accumulated and counted. Here we can see cells passing through a single file, and laser beam is focused from one side and light is scattered according to size, complexity, granularity, and diameter of cell, which are detected by photodetectors. The amount of light scattered is proportional to the surface area and therefore the volume of the cell, so that the height of the electrical pulses can be used to estimate the cell volume. Variables measured by using optical light scatter are the five-part differentials: neutrophils, eosinophils, basophils, lymphocytes, and monocytes, RBC count including mean cell volume. Hydrodynamic focusing. In this, the sample is injected into a stream of sheet fluid within the flow chamber. They are forced into the center of the stream, forming a single file by the principle of hydrodynamic focusing. The cells are hydrodynamically focused so that only one cell or particle can pass through the laser beam at a given moment. This ensures that the cells are evaluated one at a time so that the information from one cell does not overlap with the other. Types of automated analyzers. Basically, there are two types, 3-part and 5-part automated analyzers. 3-part differentiate cells into three categories, granulocytes, lymphocytes, and neutrophils. 5-part differentiate cells into five basic leukocyte types, neutrophils, lymphocytes, eosinophils, basophils, and monocytes. 3-part analyzer, principles of measurement, direct measurement, RBC using principle of impedance and hydrodynamic focusing, WBC impedance and hydrodynamic focusing, platelets using impedance, hemoglobin using Steinmetz hemoglobin method, MCV mean RBC volume by using histograms. Indirect measurement, hematocrit, MCHC and MCH, RDW and MPV, WBC differential, volume, conductivity and scatter, and reticulocyte count. 3-part analyzer instruments. It consists of two chambers, RBC side and WBC side. RBC side, cells with volume between 2 to 30 femtoliters are counted as platelets, and those with greater than 36 femtoliters are counted as RBC in RBC platelet chamber. Whereas in WBC side, after adding a lysing agent, cells between 35 to 90 femtoliters are counted as lymphocytes, 90 to 160 femtoliters are counted as mononuclear cells, monocytes, eosinophils and basophils, and cells more than 160 femtoliters are counted as granulocytes, that is neutrophils. Hemoglobin estimation. Estimated from a part of blood mixed with lysing agent to lyse the RBCs. Hemoglobin is estimated by using Steinmetz hemoglobin method, that is Drapkin's reagent. The newer models use sodium lauryl sulfate instead of Drapkin's reagent, which is cyanide free and rapidly converts hemoglobin into detectable chromogen. Hemoglobin can also be estimated by using colorimetric method. RBC platelet histogram. In this histogram, x-axis represents the cell size and y-axis represents the number of cells. Platelets have a size between 8 to 12 femtoliters and are counted between 2 to 30 femtoliters. RBC have a size between 80 to 100 femtoliters and are counted between 25 to 250 femtoliter. The size distribution curve should always start on the baseline and fall between the lower and upper discriminator. Erythrocyte histogram flagging. RL flag, abnormal height at lower discriminator. Possible causes include giant platelets, microerythrocytes, fragmented RBC, platelet lumps. RU flag, abnormal height at upper discriminator. Possible causes include cold agglutination, RBC agglutination, and Role formation. Multiple peaks. Possible causes are iron deficiency in recovery, dimorphic picture, multiple RBC transfusions, and extreme leukocytosis. Red cell distribution width. Narrow distribution curve indicates homogeneous population of red cells and RDW is less than 15. Wide distribution curve indicates heterogeneous population of red cells, indicating moderate to marked anisocytosis, and RDW is increased. RDW-CV, normal range is 11 to 16%. RDW standard deviation is 20% of the total height of distribution curve. Normal range is 37 to 46 femtoliters and it becomes clinically relevant above 60 femtoliters. DW flag, abnormal histogram distribution. Histogram curve does not match the 20% line twice. Possible causes similar as RL or RU. WBC histogram. WBC histogram showing a lower discriminator fluctuating between 30 to 60 femtoliter and an upper discriminator fixed at 300 femtoliter. The number of cells between LD and UD is WBC count. The peak between LD and T1 represents small cells, that is lymphocytes. The peak between T1 and T2 represents the middle cell count, which includes eosinophils, monocytes, blasts, promyelocytes, myelocytes, and metamyelocytes. The peak after T2 represents neutrophils. WBC flags. WL flag curve does not begin at the baseline. Possible causes: platelet aggregates, clotted sample or EDTA incompatibility, lyse resistant red blood cells, erythroblast, cryoagglutinates, and giant platelets. WU flag curve does not end at the base of the line. Possible cause may be high leukocyte count. T1 T2 flags. T1 and T2 are valid discriminators defined by the plateau. The discriminators are flexible and will be set automatically according to the sample. In special cases, is a separation from the valid discriminators not possible. In this first image, T1 could not be detected. It may be due to high number of large or atypical lymphocytes. In the second graph, T1 was detected but not T2 due to neutrophilic hypolibation. Abnormal WBC histograms in various conditions. Platelet histogram. Platelet histogram showing flexible lower discriminator set at 2 to 6 femtoliter, upper discriminator at 12 to 30 femtoliter and a fixed discriminator at 12 femtoliter. Platelet flags. PL flag. Abnormal height at lower discriminator. Possible causes: high Planck value, cell fragments, high number of bacteria, contaminated reagent, and platelet aggregation. PU flag. Abnormal height at upper discriminator. The curve does not end on the baseline. Possible causes may be platelet clumps due to EDTA incompatibility, clotted sample, giant platelets, microerythrocytes, or fragmented RBC. Multiple peaks. Possible causes: platelet anisocytosis, recovery after chemotherapy, platelet aggregation, or platelet transfusion. 5-part differential counter. It differentiates neutrophils, eosinophils, basophil, lymphocytes, and monocytes. Various technologies used for these cell counters are volume conductivity scatter, fluorescence and flow cytometry, peroxidase staining, optical light scatter technology, impedance, and immunological principle. Volume conductivity scatter. Volume indicates size, conductivity indicates internal composition, and light scatter indicates cell shape or surface. Volume. VCS utilizes the Coulter principle of electrical impedance to measure the volume that the entire cell displaces in an isotonic diluent. This method accurately measures all cell types regardless of their orientation in the light path. Conductivity. Alternating current in the radio frequency range short circuits the bipolar lipid layer of cell membrane and energy penetrates the cell. The probe collects information about internal structure of the cell, including chemical composition and nuclear volume, and also cell size. Scatter. Laser beam falls on the cell. The scattered light spreads out in all directions. Median angle light scatter signals are detected and information about cellular granularity, nuclear lobularity, and cell surface structure is collected. 3D cellular analysis. As WBCs and RBCs are analyzed by VCS technology, volume, conductivity, scatter, opacity, and rotated light scatter measurements are taken. Each cell is then assigned an X, Y, and Z coordinates in a 3D array based respectively on its RLS and opacity, volume and opacity. In a normal data plot, various cells can be seen in clusters by using VCS technology. Dot plot or scattergram. Differential scattergram of WBC representing neutrophil plus basophils, eosinophils, lymphocytes and monocytes as distinct clusters. Forward light scatter intensity indicates cell volume and side scatter represents the complexity of cellular residues. Basophils appear as a separate population. Residual nuclei are also separated from ghosts. The sum of basophils and Bayer nuclei is the total WBC count. Normal sample report analysis. Normal sample WBC count and differential were normal. The location and aggregation of scattergram were normal. The borderline was clear. No flags of abnormal cells were displayed. Histograms of RBC and platelet were normal. Fluorescence and flow cytometry. This technology is employed for platelet counts and reticulocyte counts based on the principle that immature platelets and reticulocytes contain RNA which can be stained by fluorescent dyes. Peroxide-based counters. Myeloperoxidase is used to count neutrophils. Lymphocytes are not stained. Fluorescence-based. Retic and platelet count. Immature platelets can be detected best. Immunological based. Accurate platelet count using CD41 or 61 antibodies. Newer parameters on cell counters. Nucleated RBC, immature granulocytes, hematopoietic progenitor cells, immature reticulocyte fraction, RBC fragments, reticulated platelets, reticulocyte indices, and malarial parasites. Cellular hemoglobin concentration mean uses light scatter technology and gives true estimate of hypochromia in iron deficiency anemia. Hemoglobin distribution width, degree of variation in red cell hemoglobinization, and it ranges from 1.82 to 2.64. Nucleated red cells, NRBCs identified, separated, and corrected, count obtained. WBC have high fluorescence and forward scatter. Reticulocytes, various dyes and fluorochromes bind with RNA. Immature reticulocyte fraction is the sum of MFR and HFR, that is the immature reticulocytes, and is referred to as the reticulocyte maturation index. Reticulocyte hemoglobin equivalent. Hemoglobin content of freshly prepared RBC. It gives real-time information on iron supply to erythropoiesis, helps in early detection of iron deficiency, and helps to differentiate between iron deficiency anemia and anemia due to chronic disease. Platelet large cell ratio. Percentage of platelets with a volume more than 12 femtoliters due to platelet aggregates, microerythrocytes, and giant platelets. Reticulated platelets or immature platelet fraction. Newly produced platelets that have remains of RNA in their cytoplasm, and it reflects rate of thrombopoiesis. Reticulocytes. Automated reticulocyte counts have been developed by using the fact that various dyes and fluorochromes combine with RNA of reticulocytes. Fluorescent cells can be enumerated using a flow cytometer. Usefulness of hematology analyzers. It is a rapid and efficient tool for handling of a large number of samples. The results are accurate and precise. It enables one to perform multiple tests on a single platform. Significant reduction of labor requirements. It is very important for accurate determination of red cell indices, reticulocyte count, platelet count, and newer parameters. Pitfalls of hematology. A large cell counter may give false low or high values of the red cell count. False low values may be obtained in cases of clotted sample, severe microcytosis, agglutination, cryoglobulins, and in vitro hemolysis. False high values may be obtained in cases of leukocytosis, thrombocytosis, and giant platelets. Autoanalyzers are unable to differentiate between reticulocytes, basophilic stippling, and Howell-Jolly bodies. Similarly, important diagnostic clues that get highlighted in a well-made reticulocyte preparation, like presence of golf ball HbH inclusions in alpha thalassemia and Heinz body in G6PD deficiency, may be completely missed. At times, a falsely high WBC count may be obtained in the presence of significant number of circulating NRBCs. Comments on cell morphology cannot be generated by autoanalyzers, though counters based on VCS technology give an indication of blast cells and immature cells. Giant platelets have a large size, and some of the autoanalyzers cannot discriminate them clearly from RBCs. However, counters based on fluorescence, CD41 or 61, give an accurate platelet count. Platelet clumps are counted as a single impulse and leads to falsely low platelet counts. Automation in coagulation. Screening tests include PT, APTT, fibrinogen, and D-dimer. Specific tests include platelet aggregation studies, specific coagulation factor assay, antithrombin, protein C activity, etc. Automated methods. In automated instruments, all reagents are automatically pipetted by the instrument. Timers are initiated and clot formation detected automatically. Methods of endpoint detection are mechanical, optical, and electrochemical. Mechanical method. It includes magnetic steel ball method. It's a mechanical clot detection, involves monitoring the movement of a steel ball within the solution using a magnetic sensor. As clot formation occurs, the movement of the ball changes, which is detected by the sensor. Optical detection method. As the plasma sample clots, it becomes more optically dense and the amount of light falling on a photosensitive detector decreases. The drop or change in light is determined as the endpoint, which is known as turbidometric method. Nephelometric method. The nephelometer uses a light emitting diode at a high wavelength to detect variations in light scatter as fibrin clot is formed. When the light rays encounter insoluble complexes such as fibrin strands, they are scattered at 90-degree angle. Chromogenic method. Chromogenic or amidolytic methodology is based on the use of specific color producing substances known as chromophore. Normally used chromophore is para-nitroaniline. Immunologic method. Immunologic tests are based on antigen-antibody reactions. Latex microparticles are coated with a specific antibody directed against antigen. A beam of monochromatic light is then passed. Formation of agglutination leads to increase in turbidity of the test solution and increase in adsorbance, which in turn is proportional to the antigen level present in the sample. Electrochemical method. The ion ratio single use test strip has a sample well where blood is applied. Reagents start the coagulation process. The device detects a change in electrical resistance when blood clots. Thromboelastography. TEG provides an effective and convenient means of monitoring whole blood coagulation. It evaluates the elastic properties of the whole blood and provides a global assessment of hemostatic function. It is recommended and commonly used in assessing hemostasis during liver transplantation, obstetric procedures, and cardiac surgery. The test sample is placed in an oscillating cup at 37 degrees. A pin is suspended from the torsion wire into the blood sample. Development of fibrin strands couple the motion of the cup to the pin, which is directly proportional to the clot strength. Increased tension in the wire is detected by the electromagnetic transducer. An electric signal is amplified to create a trace which is displayed on the computer screen. TEG graphic result. R time, time of latency from start of test to initial fibrin formation. K time, time taken to achieve a certain level of clot strength. Alpha angle measures the speed at which fibrin buildup and cross-linking takes place. Maximum amplitude is the ultimate strength of the fibrin. This is how a normal TEG graph looks, and this is the TEG graph pattern in various conditions. Advantages of TEG. TEG continuously evaluates clot formation, its strength, platelet function until eventual clot lysis or retraction. It is dynamic and gives information on the entire coagulation process and not just an isolated part. Flow cytometry. Immunophenotyping of cells is one of the most important clinical applications of flow cytometry. It is used to detect cell surface antigens using monoclonal antibodies conjugated with different fluorochromes. Uses of flow cytometry includes diagnosis, assess response to therapy, prognosis and detection of minimal residual disease. Indications: acute leukemias, chronic lymphoproliferative disorders, myelodysplastic syndrome, plasma cell dyscrasias, red cell disorders including PNH, fetal cell estimation, hereditary spherocytosis, reticulocyte estimation, and platelet disorders. The common elements in all flow cytometers include a light source, fluid lines and controls to direct a liquid stream containing particles through the focused light beam, an electronic network for detecting the light signals coming from the particles as they pass through the light beam and then converting the signals to numbers that are proportional to the light intensity. Principle of flow cytometer. Flow cytometer is composed of three main compartments or systems: the flow system, the optical system, and the electronic system. The specimen must be in monodisperse suspension. In this, isotonic fluid is forced under pressure where a fluid column with laminar flow and a high flow rate is generated. The sample is introduced into the flow cell in the center of the sheet fluid, creating a coaxial stream so that they are presented to the light beam one at a time. The emitted light is focused by a lens onto fiber optic cables and transmitted to octagonal detectors. The sensors convert photons to electrical impulses that are proportional to the number of photons received and to the number of fluorochrome molecules bound to the cell. Sample preparation and processing. Types of samples. Flow cytometry can be performed on peripheral blood, bone marrow aspirates, body fluids, lymph node aspirates, and single cell suspensions from solid tissue specimens. Anticoagulants. EDTA is the anticoagulant of choice for blood and bone marrow aspirates. Sample storage. The sample should ideally be processed within 48 hours of collection. Specimen integrity. Sample processing involves three major steps: lysis of red blood cells, removal of lysed red cells, and staining with fluorochrome labeled monoclonal antibodies. Automation in ESR. It is fully automated analyzer, no reagents are required, direct use of primary EDTA tubes, no contact with blood. Photometric infrared reading prevents the interference caused by lipids or bilirubin in the sample. High performance liquid chromatography. HPLC is a chromatographic technique that can separate a mixture of compounds. Type of liquid chromatography where the sample is forced through a column that is packed with a stationary phase composed of irregular or spherically placed particles, a porous monolithic layer. Principle. HPLC depends on the interchange of charged groups on the ion exchange material with charged groups on the hemoglobin molecule. When a hemosylate containing a mixture of hemoglobins is adsorbed onto the resin, the rate of elution of different hemoglobins is determined by pH and ionic strength of any buffer applied to the column. With automated systems now in use, elution of the charged molecules is achieved by continually changing. Fractions are detected as they pass through an UV or visible light detector and are recorded on an integrating computer system. Advantages of HPLC. This is an automated technique, so less time is required and permits processing of large batches. Very small samples are sufficient for analysis till is specially useful for pediatric work. Quantification of normal and abnormal hemoglobin variants can be done on each sample. The method is highly sensitive and specific. Uses of HPLC: diagnosis of beta thalassemia trait, diagnosis of HBD Punjab, HBE, HBS, and HBQ India, homozygous, heterozygous, and double heterozygous. Preoperative screening of HBS cases, diagnosis of HBH disease, diagnosis of rare hemoglobins, diagnosis of hereditary persistence of fetal hemoglobin, antenatal screening for thalassemia and sickle cell disease. Conclusion: the automation in hematology is efficient, lack inter-observer variability and size distribution curves. They give an estimate of many variables which are manually not possible and produce data with increased reliability, precision, and accuracy. Data can be stored in automated analyzers. These are my references. Thank you.